So I'm told that we are now live, and so let me say a very good day to you good colleagues from all over the world. You've literally registered from all parts of our planet. Welcome to our webinar on arboviruses in the Asia Pacific region. And thank you for setting aside time to learn more about recent findings or a status update of what's happening with arboviruses across the Asia Pacific region. This webinar is brought to you by Malaria Consortium, which is an international NGO with offices in 11 countries in Africa and 3 here in mainland Asia. I'm based here in the Thailand office in Bangkok, very happily so, I might add. But despite our name, Malaria Consortium, we do not only work on malaria, we also work on arboviruses, pneumonia, cervical cancer, and several other public health issues. So why should we talk about arboviruses? And that's because it is a problem that is growing and it will continue to increase, not just in overall case numbers, but also in geographic extent. We've seen that happening in Europe and multiple other parts of the world. It's a problem that is not going to go away, and we better become more aware of the nature and the impact of these arboviruses. We need to improve our surveillance and preparedness to respond, not if, but when an outbreak happens in our particular country. More than 70% of the several hundred million annual cases of dengue each year occur in Asia, and the authorities in many countries will quietly tell you that arboviruses are actually a bigger problem in their countries than malaria. But it is not politically correct to admit this to donors who want to focus on malaria. So today we are fortunate to have a panel of specialists in arboviruses that will share some of their insights about arboviruses in the Asia Pacific region. Before I introduce our first speaker, allow me to very quickly summarize how the webinar will work. The webinar is being recorded and everyone will be able to access it within the next 72 hours using the link we will place in the chat box. Panelists are live, but for reasons of trying to minimize background noise and distractions, we have put all our audience members on mute. Sorry about that. However, we encourage everyone to actively participate by placing questions to our panelists in the Q&A box. For example, if you have a question, give the name of the panelist you would prefer to respond to your question, and then write your question next to that name. In the Q&A box, we're not going to monitor the chat box for questions. This becomes too much of a mess. So put your questions in the Q&A box, please, not the chat box. We will have all 5 presentations back to back and then open up the Q&A session. And then right at the end of the webinar, we will put up a short poll with just 4 quick questions and a tick box choice of responses. Please spend the 1 minute responding to the poll, as it helps us understand what we are doing right or wrong and improve our ability to hold effective webinars. Okay, so let's move to the talks. Our first presentation is going to be by Dr. Amanda Murphy. Thank you to Amanda. Amanda has been very ill over the past several days with COVID. COVID hasn't left our shores. It's still very much lurking in the background. But Amanda has bitten the bullet and she's persisting, and she's going to give us a talk. So Amanda is going to talk to us about arboviruses in the Pacific Islands and what is being done about it. Amanda is a medical entomologist specializing in arboviral ecology at James Cook University in Australia. She currently co-leads the PACMOSI project in the Pacific region, which aims to strengthen capacity for vector surveillance and control through training, technical guidance, and targeted operational research. Dr. Murphy has experience spanning public health, academia, and the private sector, and she has coordinated multiple dengue and malaria projects across the Asia Pacific. Most recently, she served as a vector surveillance and control specialist for the World Health Organization in Fiji and Vanuatu. So, Amanda, over to you, and thank you again for being so brave and strong to be part of this webinar. Thank you. Over to you.
Thank you so much, Leo. And thank you so much for inviting me to present and give a little bit of a perspective from the Pacific Islands part of the world. So today, as you said, I'll talk a little bit about the situation in the Pacific and also talk a little bit about the work that myself and my colleagues are doing in the Pacific. Just to check you can see my screen okay?
Looks good. Looks good. Please proceed.
Okay. All right. Very good. Okay, so for those who are unfamiliar with the Pacific region, just to show briefly, it's a huge region. It's hundreds and hundreds of islands spread across a vast ocean, and we generally break this up into three geographic subregions: Polynesia, Micronesia, and Melanesia. And across this region, we have very widespread transmission of arboviruses. There's also malaria in just the Melanesian region as well. So just to give you an idea of the context, the other really interesting thing about the Pacific is it has the highest number of dengue vectors in the world, 13 of them, which I've popped up there on the screen. And so that adds additional challenge for us in terms of vector control, which is our main thing that we do in our project, because we need to have a good understanding of all these different vectors that could transmit dengue and where their breeding sites are and how to control them, etc. So to give you a picture of the last couple of decades of arbovirus transmission in the Pacific, you can see here that we have the three main arboviruses that have been detected are dengue in the dark blue, which is by far the dominant one, chikungunya, which came through for a few years there, and almost at the same time, there was also Zika shown in orange. And these outbreaks have been increasing in both frequency and like the geographic spread across the Pacific in the recent decades, which has been much cause for concern and part of the reason why the project that I work on was instigated. And just to illustrate the spread across the Pacific, this is showing just specifically the different serotypes of dengue that have been detected over roughly the same time period. And so all four serotypes circulate at any different given time across the Pacific. And depending on the isolation, some islands tend to be a little bit more protected than others from outbreaks. It's all about that human traffic and trade. So in a geographic region this vast and diverse, it's quite tricky to keep track of. And the other complicating factor is that, as Leo said, is the case in many countries, people tend to underreport and undervalue the importance of these epidemics, and the reported cases are likely far less than the reality. And so because of this, to help address this problem, in 2020, the PACMOSI project was instigated, which stands for Pacific Mosquito Surveillance Strengthening for Impact. It's a bit of a mouthful, but you have to have a good acronym. And this is a partnership of 21 Pacific Island countries and territories. We work closely with the ministries or departments of health in each one, and particularly the environmental health officers, and seven institutional partners led by James Cook University, and where I'm based. We work closely with the Pacific community in the Pacific and a few other Pacific and Australian organisations. And our main goal is to strengthen the vector surveillance and control programs in the Pacific, recognising that vector control is the main prevention and control tool for these diseases. So I'm not going to have time to go into all the things that we do in our program. We try to cover comprehensively all the things that a well-functioning vector control program would need to do a good job at control. Today, I'm just going to briefly focus on a few of these. So besides doing needs assessments and developing national strategies for for these countries. We also spend a lot of time doing training through different methods and various other activities that I'll only touch upon briefly. There's some links at the bottom there if you get to have a look later, which explain a little bit more, and of course go to our website and have a look. But I wanted to highlight our online training program, which I'm showing on the screen here a few sort of slides from. We try to make it really interactive with a lot of live videos and interactive quizzes and things like that. And this covers everything from basic mosquito surveillance and control to community engagement, operational research, data management. There's 8 different modules or topic areas, and that's completely free and open access. You only need to register through the PACMOSI website, and we have hundreds of users in the Pacific but also globally who've logged on to take our training. So I encourage you to have a look at that. In addition to the free training, we also have a lot of free downloadable resources on our website to help anyone working in vector surveillance and control in the Pacific to do their jobs essentially. And then to complement the online resources and the online training, we also do face-to-face workshops, which are usually regional workshops with representatives from all of the 21 countries invited, and we do those every year on different topics, and we try to complement those with individual in-country mentoring for people that request it, and where we can't do that in every country, but we have done quite a few in-country visits to provide follow-up support. And finally, the other few things that we do to support countries in a nutshell, in a very brief nutshell, is we provide vector surveillance and control equipment. So we literally send every one of those countries in the Pacific the basics that they need to be able to trap mosquitoes, rear mosquitoes in a very basic lab, identify mosquitoes. We send them microscopes, etc., etc. We provide them support to capture their mosquito surveillance data electronically rather than on bits of paper or Excel databases that get lost. We support countries that are interested to develop national strategic plans for how to control vectors of dengue and other diseases. So far, we've completed 4, and we've helped other countries update their existing plans. So that's been an impact that we're quite proud of. And then we have various types of small grants for operational research, also for citizen science and community engagement as well, that we run periodically. It's not every year. And through this combination of efforts from the training through to the supplies and the other types of support we offer, we hope in the end that we will be able to build a more skilled and well-equipped workforce in the Pacific to be able to better combat these mosquito-borne diseases. A very positive offshoot of our work is that we bring together people, wonderful people from the Pacific very regularly. And through the past 4 years that we've been in operation, we've now developed a really strong network of people working in mosquito surveillance and control across the Pacific. And these are some of my very beloved colleagues from the Pacific. I thought I would finish on that note, acknowledging them and also the rest of our consortium partners in the Pacific, and happy to answer any questions if anyone has any. And thank you so much.
Amanda, we're holding all the questions for the Q&A session after all the speakers have delivered their presentations. So we'll do it all in one big bang shoot at the end. But thank you for that very helpful overview, insight into the PACMOSI program. I have been an avid follower of what PACMOSI is doing, and I can tell our audience members that it's a wonderful, highly productive, and very relevant program. So well done to you and your team. I note that there's quite a strong contingent of people listening in from Papua New Guinea. So to our colleagues from Papua New Guinea listening in, Thank you so much for setting aside time to join. Also, a good number of people listening in from Africa, despite the early hour. So to our colleagues in Nigeria and various other countries in Africa listening in, thank you as well to you. So Amanda, thank you. There'll certainly be questions for you. Let's wait till the end. Wulan, I don't know if Paula has been able to join us. Can you see if Paula is with us?
Yeah, she's here.
Yes.
Ah, okay. My apologies. So, welcome aboard, Paula. Thank you for joining us. Our next speaker is going to be Dr. Paula Diones. Apologies if I'm getting your surname wrong. Who will share with us some insights into the epidemiology and characterization of dengue, chikungunya, and Zika viral infections in a tertiary hospital in the Philippines. Dr. Diones serves as the deputy head of the Walter Reed Army Institute of Research in Manila in the Philippines. She earned her Doctor of Medicine degree from the University of Santo Tomas. And before joining Walter Reed AFRAMS, she spearheaded the first biorisk management project at the Armed Forces of the Philippines Medical Services School. Currently, Paula manages operations at the AFRAMS, which stands for Armed Forces Research Institute for Medical Sciences Collaborative Molecular Laboratory, a reference laboratory overseeing research on emerging and re-emerging infectious diseases of public health concern. So thank you for being part of this webinar, Paula. We look forward to your presentation. Over to you.
Hello. So, good morning, good afternoon, good evening to everyone. Thank you, Dr. Leo Brack, for this opportunity to present to you our surveillance, especially here in the Philippines. So what I'm going to present to you is the epidemiology and characterization of dengue, chikungunya, Zika, particularly here in a military hospital in the tertiary hospital here in the Philippines. So just to provide a background, as mentioned by Dr. Leo, I serve as a deputy head and I oversee the activities here at the AFPMC, Afflictions Collaborative Molecular Laboratory. It's a BSL-2 laboratory located in a tertiary hospital within Metro Manila. So we've been conducting the vector-borne illnesses surveillance here in the Philippines. And what I'm going to present to you are the results of our surveillance for dengue, chikungunya, and Zika. So, yeah, this is just a disclaimer. So arbovirus infections, particularly dengue, chikungunya, and Zika, have emerged as a significant global public health challenges. So these viruses, as we all know, share a common vector, and they often circulate within the same geographic regions, exacerbating their impact on affected populations. And what is very challenging with these infections is that their clinical symptoms are overlapping and they are usually non-specific, and this is complicated by the identification of the causative agent. And without an accurate laboratory confirmation, the surveillance data may fail to represent the true epidemiological patterns of these diseases. And accurate laboratory testing is a critical component indeed for surveillance and control efforts for arboviral diseases. So this study, or the surveillance that we have in the Philippines, particularly aims to determine the epidemiological trends of dengue, chikungunya, and Zika with the use of three main methods, which are polymerase chain reaction, PCR, next generation sequencing, and bioinformatics analysis. So our surveillance, we have a protocol, febrile vector-borne illnesses protocol, by which we obtained approval from the Walter Reed Army Institute of Research and the local ethics board, which is the AFP, from the AFP Medical Center. So upon approval and implementation of this surveillance project, so we obtained patient consent. We get the demographic data of the patient, and we also perform specimen collection, particularly blood collection for our subjects. And those we have our inclusion criteria, of course, patients who are presenting with fever within 5 days and who are clinically like considered to have dengue, chikungunya, or Zika are enrolled and are invited to become part of the surveillance. So the specimens are undergo polymerase undergo like PCR. We use either conventional or real-time PCR for to test for these infections. And selected specimens are also undergo a virus isolation as well as next generation sequencing. And thereafter, we perform bioinformatic analysis. So our specimens are initially um, are in our specimens are initially tested here locally, and some of our specimens are also but especially in Bangkok for further testing and analysis. So this is just to show you dengue and chikungunya surveillance from March 21, 2022 to August 21, 2024. And later, I will share with you the significant results of our study. So this is the next generation sequencing that we did. So for dengue virus 1, um, the predominant type was genotype 4. For dengue 2, it was cosmopolitan. For dengue 3, it was genotype 1, and dengue 4, genotype 2. So you can see those that are highlighted in red. And for chikungunya, we were able to check. We were able to see that there was one specimen with the Asian urban lineage. So these are the highlights of our surveillance. So dengue was hyperendemic with all four serotypes circulating over the past years. And we observe a shift in dengue serotype with dengue 3 being predominant serotype prior to COVID-19 pandemic, and dengue 1 emerging as the dominant serotype in 2022 and 2023. However, in 2024, serotype 3 was the predominant one. For the next generation sequencing, as mentioned earlier, we identified one major genotype for each dengue virus serotype persisted. For dengue 1, it was genotype 4, dengue 2, cosmopolitan, dengue 3, genotype 1, and dengue 4, genotype 2, with clade extinction and replacement events not observed. We also observed that there was a genotype shift from dengue 4 in 2022 among 40% of samples to dengue 1 in 2023 among 57% of the samples. So chikungunya was detected in 3% of our samples, and we also observed that chikungunya peaked during the rainy season. And when we performed isolation and sequencing, it showed, as mentioned earlier, Asian urban lineage, which have the same genotype detected 10 years ago in a similar setting, since we were also conducting surveillance for chikungunya over the past years. So just to reiterate, Zika was not detected among the 172 samples process. So in conclusion, there was a low circulation of chikungunya observed with the background of hyperendemic dengue transmission, and genotype persistence was observed in chikungunya virus and across all four dengue serotypes. And for this surveillance, Zika virus was not detected. So I think that's a short report of what we're doing here at the here in a research laboratory in the Philippines. So thank you very much.
It's for us to thank you, Paula. So thank you for that very interesting and helpful understanding of what's happening with the viruses you mentioned there, dengue, Zika, chikungunya. Interesting that you haven't found Zika, at least in the sample batch you tested. But if I understand correctly, it looks like dengue, at least in the recent times, is increasing, probably going to maintain that pattern of increase. So thank you, Paula. No doubt there will be many questions or some questions directed to you during question and answer session. Just for interest's sake, to our audience members, we're currently standing about 156 people listening in from all over the world. Very happy to say there seems to be a strong contingent also from Africa, including several from Uganda, also Dr. Lutwama, and so on. So welcome to our colleagues from Africa. Thank you for getting up early to take part in this webinar. So we are now going to move on to our next presenter, who is Dr. Najmul Haider, and his topic is going to be on characterizing the 2023 dengue outbreak in Bangladesh. Dr. Haider is an epidemiologist at Keele University in the United Kingdom, where it is very early and very cold right now. So Najmul, from all of us, sincere thank you for getting up early, for your efforts to be part of this webinar. Thank you for that. Najmul's focus is on infectious diseases in South Asia and Sub-Saharan Africa. Originally trained as a veterinarian, Najmul now targets two primary areas: One Health strategies for addressing emerging infectious diseases with pandemic potential, and secondly, the transmission dynamics of arboviruses. So without further ado, Dr. Haider, thank you again, and over to you.
Hi, and thank you, and welcome to my discussion on dengue in Bangladesh. So I'll be discussing on 2 decades of outbreak and little on the impact of climate change. So these are the studies that I have done in last few years. So I'll start with these slides on the record number of cases and deaths that we have observed in 2023, with more than 6.5 million cases globally and more than 6,800 deaths. And this was the first landmark for both numbers for dengue cases. These are the number for that are recorded. We know there are a large number of these is not recorded. In 2023, while the world has recorded 6,800 deaths, Bangladesh recorded more than 1,700 deaths, which is 25% of the global record. So it's a small country, but contribute large for dengue cases and death in the world. We have also observed in 2024 that the record made in 2023 has broken for both cases and deaths for more than 14 million cases and more than 10,000 deaths recorded in 2024. So today I'll be discussing on dengue cases in Bangladesh for last 2 decades, including some comparison of the cases, deaths, and some weather patterns. So from January 2000 to December 2024, Bangladesh recorded a total of more than 600,000 cases and 3,000 deaths, which estimates a case fatality rate of 0.47%. And Bangladesh has reported all 4 serotypes in different time period. 2 major vectors, Aedes aegypti and Aedes albopictus, is recorded in different parts of the country. Although this number looks very big, these are probably the tip of the iceberg, as the number are recorded from only 5% of the hospital settings of the country. An important observation of this number is that most of the cases, around 79% of the cases of this period was recorded after COVID-19 pandemic, only in 4 years, between 2011, 2021 and 2024. And during this period, more than 80%, 85% death of the entire period was recorded in only 4 years. So today I'll compare the cases, deaths, and climate pattern of the first decade, starting from 2000 to 2010, which will be compared with the recent period, like 2011 to 2024. So let's see what happened in the first decade. In between 2000 and 2010, we observed more than 2,000 annual cases per year on average, which has increased to 47,000, which is an increase of 22 times for annual mean dengue cases in Bangladesh. For deaths, the number has increased to 11 times, from 21 on average per year to 220 per year. Now, if we look at the temperature has increased to 0.49 degrees Celsius. So if we put this temperature in the perspective of vector-borne disease, that's around 4,292 degree hours per year. So this is, in epidemiology, we use person year. So here, if you multiply the temperature with the hours, sorry, it's around 4,000 degree hours. So if we compare that with Aedes mosquitoes and dengue virus, to complete an extensive incubation period of dengue virus in Aedes mosquito, it takes around 350 degree hours. So that means that these additional temperatures allowing almost 10 generation of transmission cycles in Bangladesh in only 1 decade. Rainfall. So rainfall has decreased in Bangladesh, not surprisingly, because of this deforestation and urbanization. But sorry, rainfall has mostly actually reduced in the monsoon time, but during the non-monsoon time, pre and post monsoon time, rainfall remain almost same. So that will happen. What happens is there is an unusual rainfall during the pre and post monsoon, so which is allowing extended vector season for dengue. So let's give some examples. So in the first decade, we have seen only a few years with unusual rainfall, but in the recent year, you can see a lot of years with unusual rainfalls. Any season that has more than 10 of rainfall, this so this is allowing an extended vector season for Aedes mosquitoes to grow, replicate, and transmit dengue virus in the country. So in 2019 outbreak, at that time it was the largest outbreak for number of cases and death. We have seen
I think
Najmul, can you hear me? Your voice is disappearing. It's happened twice now. Can I ask you just to take your microphone jack, maybe just plug it in and out and see if that improves the sound, because we're losing your voice completely periodically. And then just try again, no problem. And not sure if you want to take a swig of water to help that throat of yours. There we go. Good.
Do you hear me now?
Yes, we can hear you.
Okay. So in 2019 outbreak, the outbreak started very early in the season in February, and also that year was introduction of a new serotype 3 in the country. And then we have observed an opposite pattern in 2022 outbreak, when rainfall actually came at very late in October. And we also have seen another serotypes introduced in the country briefly for the year serotype 4. In 2023, all the record has broken with large number of cases and deaths. And it was started with the introduction of a new serotype 2. An interesting side of that outbreak is that when we plotted the cases, 86% of the dengue cases were recorded in the capital city, or within 2-kilometer radius of the hospitals of the capitals. So indicating an intense transmission around the hospital settings in the country. Age and gender, we have seen most cases in males, but most deaths in female. Most cases among the younger people, or most death among the older people are above 30 years. It's not surprising, but when we use that in a model, in a regression model, we found that only the age group, that is a 10 years age group, remains significant, indicating that with an increase of one age group of 10 years, the case fatality rate has increased by 30%. In 2023, the outbreak was fatal, and of the 1,700 deaths, 67% people died within 1 day of hospitalization. We don't know exactly why. Could it be because of the late admission, or secondary infection, or some record actually lost their primary admission in other hospitals? So government has taken a lot of initiatives to combat. Ministry of Health developed the guidelines for clinical management of dengue syndrome. There is a national strategy developed for dengue prevention and control for the period 2024 to 2030. This initiative is to make sure that the diagnostic kits and the intravenous fluid is available to all healthcare facilities in the country. Ministry of Health, led by Management Information System (MIS), they release the daily press briefing on dengue cases and death, and they are recording this since 2019. Each day they release number of cases and death due to dengue, and it includes 77 hospitals from Dhaka and 63 other hospitals across the country, including 1 hospitals from each district. And there are dedicated dengue hospitals and dengue units in different parts of the country. Vector control is primarily led by local government, the city corporations. In Dhaka city, it is mostly adulticide and few also by some larvicidal activities during the peak season. Municipality is also involved with the community engagement awareness building. IEDCR, Institute of Epidemiology, Disease Control and Research, do this pre-monsoon and post-monsoon entomological surveys each year. And recently, the government has integrated One Health approaches to surveillance, prevention, and control in dengue in Bangladesh. So I'll stop here with some summaries. So dengue cases and deaths are increasing in Bangladesh. Lifetime cumulative exposure to different serotypes makes age a key risk factor for dengue-related deaths in Bangladesh. Unusual weather, especially global warming and altered rainfall seasonality, is responsible for increased cases and deaths. And introduction of different serotypes leads to large outbreak in the country. And Bangladesh is also a country where we have a risk of other Aedes-borne diseases, including chikungunya, Zika, red belly fever, and yellow fever. Yeah, and I'd like to thank my colleagues, especially Ministry of Health, for sharing data publicly and supporting our research. Thank you.
So, Najmul, thank you for that very, very interesting presentation. And, you know, the figures you give there for 2023, I think it was more than 300,000 cases in just that 1 year, is a real wake-up call And these outbreaks in South America and Asia and so on seem to be happening more frequently and at a pretty dramatic scale. So it's a serious warning for all of us to sit up and take note and improve our preparedness, especially our colleagues in Africa, where there's apparently a great need for improved surveillance and strategic planning for improved response in the event of outbreaks that are almost certain to become more frequent and at larger scale. You teased out some very interesting findings there about age distribution and gender differences, and also particularly interesting little observation about, even although the average annual climate difference between decade 1 and decade 2 was minimal, 0.49 degrees centigrade, if I remember correctly. Even that half a degree centigrade has dramatic consequences on vector populations and the ability of those vectors to extend breeding time period and the generations per annum. So small things can have big consequences, and thank you for bringing our attention to that. Thank you, Najmul. No doubt there will be questions for you. We're going to look forward to seeing them in the chat box, in the Q&A box for Q&A session. Just for interest to our listeners, I get the impression there's about 156 people listening in so far to this webinar, 156. We now move on to our next presenter. Next up is Fikri Hassan Klaib, who will be informing us about the detection of emerging arboviruses in Indonesia. Fikri is with the Emerging Virus Division at Exain's Health Initiative in Jakarta. He graduated from the Imperial College in London, researching host proteomic biomarkers to distinguish viral and bacterial infection. He is keen on promoting multilateral partnerships in the interest of accelerating medical research against neglected tropical diseases, malaria, and tuberculosis. So thank you, Fikri. We look forward to your presentation. Over to you.
Thank you for the lovely introduction, Leo. Hi, everyone. My name is Fikri Hassan Klaib. Today, I'll be discussing the detection of emerging arboviruses in Indonesia, a scoping review. Just a quick disclaimer, the manuscript of the study is still in preparation, so this presentation may include some unpublished findings. So please refer to this presentation strictly for educational purposes. So in 2024, the WHO launched an initiative to focus on tackling mosquito-borne viruses in recognition of the multifaceted impact of these viruses on global health, economy, and the environment. In Indonesia, we have molecular, serological evidence, as well as virus isolates for 3 of these targeted viruses: chikungunya, dengue, and Zika virus. In the same year, the Ministry of Health released a guideline for a sentinel syndromic network, surveillance network, targeting 21 diseases. Of the 21 diseases, 4 are arboviruses, including yellow fever, West Nile, Zika virus, and Rift Valley fever virus. Outside of the priorities here, we also had to conduct dengue virus and chikungunya virus surveillance as part of standard practice surveillance, since these 2 viruses are endemic in the region. But what's interesting here is that the guidelines are inspired from the WHO list of public health emergency of international concern, one of which you all may recognize also includes COVID-19 during its time. However, this may not apply to pathogens uniquely circulating in Indonesia, because Indonesia has a massive landscape and a large biodiversity. So the question remains, will the real emerging arboviruses please stand up? Which arboviruses have been detected in Indonesia that pose a threat to Indonesian human health? What are the trends of detection strategies used in Indonesia to detect these viruses over the last 8 decades? What is the impact of these arboviruses in Indonesia and neighboring countries and globally? And which neglected arboviruses have potential of reemergence and outbreak capacity? So the overall objective here is to identify emerging and reemerging arboviruses between 1945 to 2023 that are of public health significance in a historic and contemporary context. So here's an image of the methodology that we had used. We used the PRISMA scoping review guidelines to conduct the methods. So it's not a new protocol per se, just added a few adaptations and modifications. We used the baseline of the international catalog to search arboviruses that might be relevant in the region that causes human disease. And using this algorithm shown, 276 articles were used to create a summary analysis of the data that's already existing in Indonesia. If you'd like to know more, the methodology is published in a protocol on the Open Science Framework. So here are some key summary findings. When we look at the publication and detection trends across 8 decades, we can see that publications on arbovirus research was most prolific in 2018. And there's a general trend of uptick in publications on arboviruses starting in 2011. What's interesting here is that this might be due to the fact that molecular detection technology like PCR and sequencing was consistently used in all publications after 2011. Prior to that, there's lots of gaps in the use of molecular detection. But overall, when we look at the historical data, serological methods looking at antigen and antibody detection is still overwhelmingly used for arbovirus surveillance in Indonesia. ELISAs, rapid diagnostic testing, and neutralization tests in particular. When we look at the distribution of studies across species, humans represent the overwhelming amount of studied of arbovirus surveillance studies, representing 74%, followed by the vectors, which are mosquitoes, as my colleagues had discussed before, they're at 13%, and the remaining animal reservoirs, in particular, five of which are wild animals, bats, birds, monkeys, orangutans, and shrews, and the rest being domestic and livestock animals. As you notice, all of these are either avian or mammals. When we look at the distribution of viruses studied across 8 decades, 50% is represented by endemic viruses circulating in the region, dengue virus, chikungunya virus, and Japanese encephalitis virus. When we look at the detection in humans, we can see that dengue virus is still predominant in the region, followed by chikungunya and Japanese encephalitis. We could also see that 11 orthoflaviviruses historically have been circulating in Indonesia. And when we look at 3 other groups, orthobunyaviruses, there's 3 orthobunyaviruses circulating in the region and having some prevalence in the region, but they only represent 2% of all arbovirus publications in the last 8 decades. Following that, there are 7 alphaviruses circulating in the region. What's interesting here is that in the orthoflaviviruses, 3 of the orthoflaviviruses are part of the Sentinel Network surveillance for the Ministry of Health. And we can see here there's prevalence shown in terms of distribution. But then we have this one particular virus, Murray Valley encephalitis virus, which has quite a high prevalence in Indonesia. But the last time this Murray Valley encephalitis seroprevalence was studied was in 1996. So there's quite a large gap in terms of what might be circulating and whether Murray Valley might still be circulating in Indonesia, about a 30-year gap. When we look at the summary characteristics of circulating arboviruses between 1945 and 2023, the viruses here highlighted in red are viruses that have never been studied for the antibody detection in Indonesia through serological methods. And when we look at when the last time it was studied in human serum serologically, and with exception with endemic viruses here, these 3 viruses, and Zika virus, all of these viruses were studied prior to the 2000s. So there's a lot of data that's being missed in almost 25-year span. And when we look at the provinces, some of these viruses are predominantly in the Papua Islands. Here is a short table on some of the other neglected viruses we were able to capture with our detection with our methodology. I'll focus on 3 in particular. So these 2 viruses, Ingawavuma virus and Bana virus, were isolated from a mosquito in Indonesia, a mosquito pool. So there's evidence of these isolates of these 2 viruses. And these 2 viruses have definite evidence of causing human disease. What's interesting is that no serological studies for these 2 viruses have ever been conducted. Ingawavuma virus was isolated in 1982 from Riau, Sumatra, and Bana virus was isolated as recent as 2016 in Bogor, a small city right next to Jakarta, our largest metropolitan city. When we look at another recent finding, our group was able to isolate Tembusu virus from a Culex species mosquito in South Sulawesi in 2023. There's some serological evidence in Indonesia, but the last time this was studied was in South Sulawesi, was studied in 1973. So what is the gaps of surveillance? I'll use 3 examples. First, the overall distribution of studies we can see here. These are the sentinel sites for the Ministry of Health Syndromic Surveillance network. Overwhelmingly, it's in Java, 2 in Sumatra, 2 in Kalimantan, 2 in Sulawesi. Now, this is very helpful in terms of the sentinel sites because they hit very key markers in Indonesia. Jakarta is the largest metropolitan city in Indonesia. Bali is a tourist destination that most people flock to. And Nusantara is supposed to be the new capital in Indonesia. But what's interesting here as well is that these 2 provinces in Sulawesi, Gorontalo and West Sulawesi, Gorontalo has never been studied for the surveillance of arboviruses in Indonesia. And the nearest sentinel site is about 400 kilometers in Manado, North Sulawesi. So there are some gaps here in terms of how we conduct surveillance in Indonesia. Another example is location. As you can see here, Zika virus has a lot of robust evidence across the multiple islands in Sumatra, in Java, even in animals in Lombok, some human evidence in Kalimantan and in Sulawesi. And so the question remains, how come there's no markers here? Well, that's because Zika virus seroprevalence has never been conducted in Papua or in North Maluku. So why is this relevant? Well, because as recent as 2019, there was a study conducted in Papua New Guinea in a small city located right here, about 100 kilometers from Jayapura. Those military personnel showed a seroprevalence of 65% against Zika virus. But we have no idea whether Zika virus is circulating here undetected in Jayapura. Jayapura is the largest city in the Papua province. When we look at time, West Nile, Kunjun virus, these viruses have been studied prior, but the last time it was conducted in Papua was in 1972, and in Sumatra, it's never been studied. When we look at the neglected viruses, as you can see here, there's many viruses spread across the islands. But I'll focus on 3 in particular. As you can see here, Tembusu, as mentioned before, was isolated in 2023, unpublished data from mosquitoes, and has serological evidence in humans in the same province. But this was last conducted in 1973. So what can we learn from this 50-year gap? Well, it's important that we start identifying new hotspots, exploring underrepresented provinces. 8 publications are recorded in East Kalimantan, where is the province posed for the new capital, and the most recent publication is 2021. Papua has a lot of diverse collection of arboviruses circulating in the region with historic seroprevalence data, but that data is outdated and pales in comparison to other Indonesian provinces. Then we ask, what about the One Health approach? Well, animal surveillance is still limited in Indonesia, as mentioned before. Only 13% of arbovirus surveillance is in animals. And with growing evidence of West Nile being detected in lizard, including a presumptive West Nile infection in a ill Komodo dragon in 2021, it's growing important to look at these animal reservoirs as opportunities for transmission. When we look at emerging pathogens, we have to start reprioritizing what might be some re-emerging and emerging arboviruses. Bana virus and Tambusu virus have been detected in vectors, but the serological testing of these arboviruses in human populations has either never been done or is limited to few studies. Rift Valley fever and other Bunyaviride viruses haven't been studied well serologically, so developing new technology that does multiplex surveillance methods will help gauge the endemicity of these viruses to determine its priority specific to Indonesia. And finally, pathogens don't respect borders. An example of that is in 2020, an Italian traveler returning from West Sumatra was infected with dengue fever and returned to the country, causing the first local outbreak of dengue in northern Italy. And in the same study for Zika virus in 2019 in military personnel, other viruses, including Bombovirus and Ross River, was detected in human sera in the same city 100 kilometers away from Jayapura city. And in regions sharing borders with Indonesia, such as Malaysia, Borneo, Papua New Guinea, and Timor-Leste, there's 12 circulating virus species that have never been isolated in Indonesia. Whether that is because of lack of studies or the viruses are not circulating in the region is a question that still remains. And I know I've taken a lot of time now, but I just wanted to introduce our institution real quick. So Excellence Health Initiatives is a premier research organization with capacity for whole genome sequencing, pathogen detection, including emerging viruses and malaria. You can find us in the field. That's me here, and this is the rest of the team. You can find us in the lab doing high quality work. You can find us disseminating our research at international conferences as well. I'd like to acknowledge to all our local partners and international collaborators for this surveillance work that we've done. Without them, it hasn't been possible. And I'd like to thank our dedicated team for the hard work we've done in the past decade doing arbovirus research. Thank you. That's all from me.
Fikri, you deserve the opportunity to do a little bit of marketing, so no problem. So, very professional, wonderful presentation. Well done, Fikri. I'm sure everyone enjoyed that, as also the previous presentations, of course. But you point out, a number of different issues there that are highly relevant. Will the real additional threats please stand up and be counted? And I think post-COVID pandemic, there's now a spate of these studies that are being funded to look for zoonotic reservoirs of infections in different parts of the world. So, and I have absolutely no doubt that new viruses or possibly other pathogens too will be discovered. And you also point out, that in our rapidly changing world of increased trade and tourism, people movements, with the general effect of climate change, global warming, exacerbating and increasing urbanization. It's just a perfect storm that's developing to facilitate and enable these epidemics to occur, and the general spread of the virus and even the vectors as well. So for those insights, Fikri, thank you so much. I have no doubt that there will be other questions directed to you as part of the Q&A session. But let's move on to our final panelist, which is Dr. Teo Boon Tiong, who's going to share with us insights into an investigation of the chikungunya outbreak in Perak, Malaysia, over the period 2019 to 2020. Dr. Teo is a senior lecturer at the Tropical Infectious Diseases Research and Education Center, shortened acronym is TIDREC, University Malaya in Malaysia. He's in charge of the WHO Collaborating Center for Arbovirus Reference and Research and technical manager of TIDREX Surveillance Laboratory. So, Dr. Tiong, Dr. Teo, we look forward to your presentation. Over to you. Thank you.
Okay, thank you, Dr. Rio, for your kind introductions. Let me share my slide. All right. Can you see?
Yeah, thank you.
Okay, yeah. Okay. Good morning, everyone. Hey, good afternoon and good morning to everyone. So my name is Boon Tiong. So my presentations are entitled Investigation of Chikungunya Outbreak in Perak, Malaysia during 2019 to 2020. So basically, this is an event that happened right before the COVID pandemic. So here, just to share some the story of our investigations that we have conducted. So this investigation started by one letter. This is a letter from a doctor in the side, the Perak there. So on 16 October 2019. So in the letter, he mentioned that there is an increased number of patients with chikungunya-like illness. However, during that time, there's no laboratory diagnosis available for the confirmations. So upon receive this letter, so in TDRAG, we actually deploy a team, including myself. So we went down. So this is the, let me bring up my pointer first. Okay, this is our research center in Kuala Lumpur. So, and this is a Perak, the red side is a Perak, and the box is a outbreak site. So it's about 200 kilometer, 2 hour drive from our center. So we went down there and we meet the doctor in the clinic Chai here. So, and the site of outbreak actually is here. It's called Kampong Baru Air Kuning. It's a small town, a small village. And because it's a small village, when the people get sick here, so they stay at home. They didn't actually seek for medical help from the clinics. So what we do here is we actually conducted an on-site investigation from house to house visit. So we follow the doctor, we visited the shop log, we visited the house, and we obtained a sample from the patients and also from the kids. And also we have a discussion with the Community Management Council to discuss about the investigations. So this is a timeline of our investigation in the Kampong Baru Air Kuning. So on 17 October, we received 6 blood sample from the patients, and we bring back to our research center and we perform the lab test on the next day. So we perform the testing for chikungunya, dengue, and also the Zika virus infections. So for the first, of the 6 samples, actually 6 were positive for chikungunya RNA, and 2 positive for chikungunya and dengue RNA is a co-infections. So then we quickly report this to the Ministry of Health, notified. Then the Ministry of Health actually, they did a very good job. On the next day, actually they performed the fogging in the regions. And of course, on 24th October, we also obtained more sample from the patients. And some sample, about 4 sample actually convalescent sample from the same patients. Then for the second report, 4 actually positive for chikungunya RNA, 2 positive for dengue RNA, and 4 convalescent sample actually tested positive for IgM, and it is indicate seroconversions, and this indicate ongoing outbreak of chikungunya in the site. So we decided to conduct a committee program for the local committee to educate them to share information how to prevent the further transmission of the disease. And also we conducted the disease surveillance. We want to see how big is the impact of the outbreaks in that site. So for the sample that we obtained from the participants, the volunteer, actually 1 tested positive for dengue, chikungunya, IgM, and 6 of them actually positive for IgM and IgG. So in total, in the Kampung Baru Air Kuning, 76% were tested chikungunya infections and 60% were dengue positive. And if you noticed here, actually from the sampling to the reporting, actually we spent about 1 week. Yeah. So I think this is not good enough in my opinion. So we think we need to improve this. So you may wondering what is a community program that we we conducted for the community. So the program is entitled Towards Better Knowledge, Attitudes, and Practice in Preventing Mosquito-Borne Disease among the local community. So we have a discussion with it's a collaboration between the Community Management Council and also the Ministry of Health. You can see the nurses here and doctor here help to conduct surveillance, set on the counter for health screenings. And here also we conducted a community talk using the local language. Like for example, in this we use the Chinese to talk to our Chinese community people. And also we have our colleague there who speak in Malay to Malay community and also the Indian communities. And here also we conducted prepared some mini game for the kids so that they can understand how is the biology and life cycle of the mosquito and how to eliminate the mosquito breeding site. So in the community program, actually we noticed that actually people there they not understand how the chikungunya virus spread. They thought it's initially they thought it's an airborne virus. So that's why we actually also educate them. So wearing mask doesn't help. So chikungunya actually is a mosquito-borne viruses. And yeah, and also during the conversation, we also get the information that the infection has spread to other region nearby the village, which is the Bido and Sungai. So from here, you can see on the top left is Kampung Baru Air Kuning, the first outbreak site. Then the virus actually spread to Bido and Sungai here. So which is a bigger town as compared to Kampung Baru Air Kuning. So in this, we decided to expand our on-site investigations. So by this time, we changed a bit our strategy. Instead of go house to house, actually we collaborate with a clinic in the town because this is a bigger town. They have the clinics. So we have 3 clinics here: Jabida Clinic, Lim Clinic in the Bido, and also the Well Medic Clinic in the Sungai. So between 16 January to 10 of February, we actually received a 15 blood sample from febrile patients. And we tested them, and 6 were positive for chikungunya RNA, 2 positive for dengue virus RNA, and 1 positive for chikungunya and dengue is co-infection, and 4 positive for chikungunya IgM. So 73.3% were chikungunya infection and 20% were dengue virus infections. So this has also confirmed that the disease actually has spread to Bido and Sungai. So this is a timeline investigation for the Bido and Sungai. So here we decided to conduct more community programs so that we can educate the people how to help to stop the transmissions. Here actually we have discussion with a lot of many community management council. There are a few group of that. So, and we conducted our second community program in primary school, which is SJKC, Kampung Baru Cold Stream. And here involve a lot of primary children, school children. And also we have also performed, conduct a disease surveillance again for the community. And we have about 38 participants. And also you can notice here in the picture here, the children actually, they got a lot of mosquito bite mark on their leg. So this surveillance actually tested about 14 positive for chikungunya IgM and IgG, 6 positive for chikungunya IgM, and 3 positive for chikungunya RNA. So actually, this indicates the disease has spread to this region as well. So about 60% of the community were tested exposed to chikungunya virus infection. So we actually plan to perform another our third community talk in another school on 9th of March is a tentative plan. Why is tentative? Because during that time, January 1st, 25th of January, there's a first COVID case landed in Malaysia. And on 4th of March, actually, our cases increased to 50, the COVID-19 positive. So that moment, actually, we decided to postpone our community talk. However, on 18 March, there's a lockdown in our country. In Malaysia, we call Movement Control Order, MCO. So after that, TDEC has been called for duty to help our country. So TDEC actually appointed as a National COVID Screening Center on 20 March to help to screen the COVID specimens. And a year later, 2021, we appointed as another medical device authority testing laboratory. This is to help to perform evaluations on the medical device, especially on the self-test COVID kits, to ensure the quality that bring into the market are of all high quality. So although the COVID pandemic has forced us to stop our community programs, so I think COVID pandemic also forced people to learn new things. So especially the self-test RTK and also the digital health notification system. In Malaysia, we use this, we call My Sejahtera. So before COVID pandemic, we don't have these two knowledge or less knowledge on these two items. So after COVID pandemic or pandemic, so actually everyone pretty aware of these two device. So self-test RTK actually is a do-it-yourself for early and rapid diagnosis, while digital health technology for early and rapid disease notifications. If these two combine together, actually we can give a very immediate response to control the disease spread. So now we try to bring this idea into the prevention of the transmission of the Arbovirus. So to stop Arbovirus spread, the first, of course, is the mosquito away. So we can install mosquito screen or we trap mosquito repellent in the house. But unfortunately, the people may get infected outside the house. So if we don't have the diagnostic test kit for the fever people, then he may travel and spread the disease to new area. So infected by the new mosquito and spread to the family and the neighbor. So you can imagine this is beetle and this is air kuning, this is a beetle, this is sunkai. So if we can detect and notify early, so actually we can perform immediate response. The public health can do fogging to stop the mosquito, infected mosquito. Then at the same time, we can educate the people, empowering the people so that they know what to do during the outbreak or when they are sick. So the first thing, I think pretty similar to the COVID is self-quarantine. But this is a bit different because it's not only quarantine for the people, but it's quarantine from the mosquito bite, quarantine from the mosquito. So the people can wear the long sleeve, long pant with the bright color and use mosquito repellents. Yeah, this is very important. So this may help to stop the transmissions and prevent the outbreaks. So in summary, so based on our investigation, 71.6% of the 82 blood specimens that we collected were positive for chikungunya RNA. So this indeed RNA IgM. So this indeed is a chikungunya outbreaks. And coupling the use of self-test kit and digital health notification system may be a feasible strategy for future pandemic preparedness, especially in the resource-limited setting. Yep. So here is my acknowledgement to the people that involved in the study. And here I am, my presentation. Thank you very much.
Dr. Tia, thank you for that very interesting presentation. Interesting to see how you responded and adapted your response to the changing situation. I really liked the summary towards the end there, where you showed how to break the transmission of or the perpetuation of the outbreak. What happens if you don't? those little pathways that you showed. So thank you for that. I think, you know, there are many people that dabble or work with arboviruses that are fascinated. This is now going off in a little bit of a tangent. Why yellow fever has not spread to Asia? I mean, yellow fever historically was from Africa, and it spread several hundred years ago to the Caribbean, and from there to other parts of the world. But it's primarily Africa and South America where yellow fever is. But the exact same vector is widespread in Asia Pacific. So why has yellow fever not spread to Asia, which is a completely naive population that will be very vulnerable to infection? And given the increasing, you know, travel and trade and movement of people between, for example, China and Africa, why has yellow fever not established itself in China for a start, and other areas? What is it that's inhibiting that spread? If anybody wants to have a try at speculating, pop it in the chat box. I'm sure there are many people that would be interested in seeing what you think. To our various panelists, thank you for fascinating array of presentations. We now move on to the question and answer session. I should mention that I've asked Dr. Mohammed Mukhtar to join us in the panel. Dr. Mukhtar is head of the Vector-Borne Disease Control Division in Pakistan, and he has a wealth of knowledge about arbovirus surveillance and control that we can use to help respond to questions. So let me go to the Q&A box here. Some of our panelists have been proactive and they've jumped in and they've already in writing responded to many of the questions. So those of you, Amanda and so on, that have started responding, very grateful for that. Let's start at the top and then just work our way down in fairness to the people who pose questions. Dr. Najmul, are there dengue treatments for the patients once they are infected? You know, I think many people will know there's actually no medication. It's preventative and symptomatic treatments. But what measures are there for the disease not to progress to death? How does one respond to an infection? Are you going to have a stab at that, Najmul?
I think you have answered the key questions, but I would like to add a little bit on this. So dengue, there is guidelines for dengue management and managing the severe patients, and I think each country now adopted the guidelines from WHO. So following the guidelines, the management is not that difficult, but we might need to remember that secondary dengue infection, which follows after the new infection with the second serotypes, is something that need to be considered as severe, and managing that need some expertise, because there is no current diagnostic test that can easily detect whether that infection is secondary or primary infections. So that with that caveat, the research should concentrate on easy way of detecting secondary cases at the early phase of the infection, so that those people can be prioritized for treatment.
Thank you, Najmul. If anybody else wants to respond, please feel free to interrupt me and add or clarification or so on. I'm going to move to the second question from Eric Murimi, and I'm going to ask Paula. I think you've been in a tertiary hospital and seen many cases. Is there an outbreak that you're aware of that has involved multiple infections of different serotypes or even viruses, you know, multiple infections in one patient. You want to have a stab at that, Paula?
Um, so thank you for that question. Well, so far for our surveillance here in the Philippines, we have not yet detected any like co-infection for multiple serotypes, sir. It's usually just one kind of serotype. So yeah.
Okay, thank you, Paula. Dr. Teal, what about you? Have you seen co-infections, different viruses?
Yeah. So we in Malaysia we also multiple dengue virus serotype. They are circulating in Malaysia. So but we performing the serotyping is not a common practice for the routine diagnostic. So usually when they perform the detection is just whether you are dengue or not dengue. So co-infections of multiple serotype, we have very limited evidence, but there are some cases, yes. Yeah.
Thank you, Dr. Teal. Dr. P.T. Joshi, nice to see you, Dr. Joshi. Thank you for being here. You gave a very long question here, and it's a bit jumbled for me to unravel, but I get the sense it's got something to do with adequate surveillance, and you're asking about larvicides and insecticides to knock down both Aedes aegypti and albopictus. So, and I think you're saying that, you know, it's useful for our audience to understand how to deal with the vectors, starting off with proper surveillance, you know what's going on with your vector population, and then implementing effective control to prevent an outbreak or to tamp down existing outbreaks. So, Dr. Mukhtar, perhaps this is a question for you. How could you give a general answer to that? Just general. I don't want you to go into detail. How does one do surveillance? And then what are the most effective ways to implement some form of vector control? Just a general, quick response, if you don't mind.
Yeah, thank you very much. And I think this is a wonderful question, because you know that the vector surveillance is the first pillar for a sustainable and a strong management of these diseases. Because you know that the vector surveillance is to provide the basic information of the type of the mosquitoes, vectors, and the behavior, where they breed, where they rest. When we find these information, then we can develop some sustainable strategy of keeping in view the behavior. Particularly, that's why surveillance is a most important pillar to develop a sustainable management strategy for these vector-borne, mosquito-borne diseases. For the particular intervention, and this is very scenario specific. My answer is a very scenario specific. When you have a particular breeding site, either is man-made inside the home, or is a general breeding site outside, out biter and out breeding site, then we can develop where we are to target that particular species. So surveillance is the most important, and then based on your surveillance data, we can find which is the actual target site where to go and which type of intervention. And I have also seen some question about the spray in one question, that the spray of the household. Yes, when we have the positive case, as we have the strategy, and even many other countries, that when you have the positive case in that particular household, we can go for the spray of that particular household, that particular and the surrounding house in the surrounding of that on each directions. So this means that when you have a very concrete evidence of this based on your surveillance, then we can find which should be the target intervention and which what we call the time and target specific intervention based on your surveillance system. Am I right? I think this is a general answer. Yeah.
No, I think it's a wonderful, concise response, spot on. So thank you very much for that insight, Dr. Mukhtar, much appreciated. I think you responded perfectly. Wulan, I think you made me aware of here, somebody raised a hand and would like to present a live vocal question. Do you want to make that person activate that person so they can ask their question, if you don't mind, Wulan?
Sure. So I let him speak.
It's Imtiaz, I think.
Yeah.
Imtiaz, if you can unmute yourself and then give us your question, please. I think get your thoughts together, and while you're doing that, here's a question here from Izatul Huda to Dr. Tiu about the symptoms of the chikungunya infections that you experienced in Bidor and Sungkai. Were these, presumably they went to a medical facility and they did so because they're not feeling well and therefore they must have had symptoms. But generally, what are the symptoms and how severe? Can you talk a little bit about the symptoms of the cases that you experienced, Dr. Teo?
Yeah, if I remember correctly, I think the early symptom especially is pretty similar to dengue. Like it's just a fever and body ache. Yeah. Then in Malaysia, usually the routine test is the clinic will perform NS1 test for dengue. Yeah, and chikungunya test is not available, especially in the resource limited setting in the rural area. So once tested dengue negative, then they will send them home. So yeah, so I think only when they get obvious when the joint pain they have a prolonged severe joint pain, then that is the one that trigger it might be chikungunya. I think that is a distinctive symptom that people can link to chikungunya. If other than that, I don't think there's any others. Yeah, I think the severe prolonged joint pain is the one that differentiate them from the dengue and other diseases.
Yeah. Thank you, Dr. Teo. So thank you for that. Here's a question here, or an observation, largely, really, from Chalachu Sisai. Thank you so much for your presentation. He's not addressing this question to any particular person. It's a general one. The incidence of dengue continues to rise in Africa, as indeed all over the world, leading to increased morbidity and mortality despite weak detection and surveillance systems. What do you think? What do you recommend to reduce arboviral diseases? Well, just a quick stab. First of all, African health ministries should become more aware of what's happening across the world, that arboviruses are becoming a stronger and stronger and more important public health threat. We cannot sit back and business as usual approaches. We need to start being more proactive in terms of preparing ourselves to understand what is the scale of the problem in our particular country, and do we have the tools and skills to confront? Are we prepared to rise to the challenge of dealing to these rising threats? So, it's a case of there are many countries in Africa that don't have a national strategic plan for arboviruses. So first off, you need to develop a strategic plan document that puts together a strategy, that embraces surveillance. You need to establish a surveillance system that will enable you to understand when, where, how much of arbovirus is actually present in your country, what kind of arboviruses are they, and then you need to, generally improve diagnostic skills, case management skills, and also outbreak response preparedness. And all of this should be captured within a national strategic plan. Who is responsible for monitoring the situation? Who is responsible for responding to a situation? What are the staff requirements? What are the resource requirements? All of this. So just start off by being more aware of the problem and prepare yourself by having a strategic plan in place. I hope that's kind of some reasonable. Does anyone else on our panel, you want to respond to that question maybe? Dr. Mukhtar?
Thank you very much, Dr. Liu. This is, in my opinion, this is one of the most important requirements for the sustainable management of these arboviruses, that you must have a very strong surveillance system, then you have this very systematic strategy of the country-specific strategy for the control of these arboviruses. And other important thing based for this strategic direction is the very strong commitment from the local government, local mean national, provincial government, for domestic resources, because there are a lot of initiatives which are the donor dependent, are donor driven, but for the sustainable management of these arboviruses, it is actually the respective government who must have the sustainable domestic resources for the management. No doubt is that when you have this strategy means you have some strategic directions for the control of these arboviruses. And for those strategy, main source of the direction should be the respective the local government. Local mean national, provincial, and the district government for the management of these. So first is the clear direction, having the very clear strategic plans, which focus should be for all the tiers, national, provincial, and the district level. And those directions should be based on some strong commitment from the local government, not entirely for the donor driven. So this is my response for the sustainable management of these arboviruses in any country. Over.
Thank you for those words of wisdom, Dr. Mukhtar. Thank you for that, spoken by a man with decades of experience in these issues. Here's a question from Amar Tiluk. With regard, is there a global database? Amanda, I'm going to direct this one to you because this one talks about small island nations. So I think you perhaps a very appropriate person. What happened to that? Oh, there's the question. Is there a global database of dengue serotypes disaggregated by countries, years, etc.? I'm particularly focusing on small island nations. So I don't know how to, he wants to know, when you see the question yourself, Amanda, geographic distribution of serotypes. Is there clustering of serotypes in time and space? And where would one find that, presumably? Something like that. Are you okay taking a stab at that, Amanda?
Yeah, absolutely. I've gotten this question before, actually, because I think when we come to tackling problems like dengue and arboviral diseases, one of the first things we want to know is, what's the distribution of disease? We need to understand the problem. And in my experience, that type of information is not captured in any global database that I know of, because most global databases are created by, donor funding when there is, perceived to be a very big problem. Whether or not there will be such a database created with WHO's new recognition of dengue being a global problem. I don't know. To date, I don't believe there is anything, and at least in my region where there is small islands, it's very difficult even to get the islands to report that they have an outbreak. The serotype is often not even reported or even tested in a lot of cases, and that's not possible without often outside support with the serotyping process. I don't know what the case is in Asia, but in the Pacific, they run a lot of labs that can do that routinely. So often it gets sent offshore and then it takes months and then maybe the answer comes back, and it's quite difficult and challenging. So one thing that we're doing in the Pacific, and I know there's other regions of the world doing the same, is creating networks for building capacity across these type of areas. So hopefully through networking, advocacy, and hopefully the ongoing work of WHO and other partners to raise global awareness, perhaps we could get a bit more improvement in this area in data sharing and data availability. I hope that helps.
Yeah, no, it definitely helps. Thank you for that. And Maxine Whitaker has also very kindly jumped in the chat box and gave a reference there that might help, provides some source material that kind of adds to addressing or providing some kind of insight to this question. Thank you for coming in, Maxine. Najmul, here's a question for you. Do you think that breeding site availability in Bangladesh may have contributed to the massive outbreak of dengue in Bangladesh, or the general trend of increase as well? And he says here, dengue mosquitoes prefer dirty water. So let me not try and unravel that further. You can read yourself there. Najmul, do you want to venture speculate a little bit about, climate change or any other, or urban development or whatever, about increasing breeding sites for vector mosquitoes?
Well, this is very interesting. Number of cases has increasing, especially post-COVID. So there are many hypotheses and many assumptions. But we need to remember that dengue cases are increasing globally. In 2023, when there was 6.5 million cases, that was a record for the world. In 2024, the global number is 14 million, especially from South America, Brazil, and other countries. Bangladesh, when in 2019 we had 100,000 cases, first time we observed 100,000 cases in a calendar year, but in 2023 there's now 300,000. So cases are increasing, and breeding factor has not dramatically changed in last 3 and 4 years, I will say. It was like as it is, or little change after the pandemic, when we returned to the post-COVID normal came. But sorry, I don't think only the breeding factor is the one. Yeah, definitely breeding factor, breeding site, habitats, they are contributing, but this is multifactorial. We have seen introduction of new serotypes, and we have seen urbanization is a major factor in Asian countries, and also in some African countries now. So all those are contributing for increasing number of cases. And last one, I think we might need to acknowledge that because of the COVID pandemic, our capacity for laboratory tests has improved globally, not only in Bangladesh. In many countries now are capable of doing those point of care test or this preliminary test. So COVID-19 gave us some capacity building for detecting cases, which is also contributing in detecting more cases. So these are the what I can remember, but I think the other expert member can add
Yeah.
this.
No, thank you, Thank you for that, Najmul. We're starting to run out of a bit of time, so I prefer to try and address a few more questions. Gideon, nice to see you being part of this webinar as well. You're a frequent participant in our APMN and other webinars. Always good to see you participate. You make the comment here that arboviral diseases are critical, increasing, causing death. Why is it that arboviruses are neglected by the global health community? So, I mean, yes, it's absolutely true what you say, that there's less funding available for arbovirus research and control and so on, and critically also surveillance. So why is that? Well, the obvious one is that there's malaria, and malaria kills percentage-wise, relative-wise, a lot more people, especially in Africa, the poorer nations, and so on. So, if there's a limited pot of funding available, as there always is, then that pot of resources gets directed to the high priority, most impactful public health threat, which is malaria. And therefore, there's very little left to redirect to things like dengue. But I agree with you that, you know, there is it leans overly heavily away from arboviruses, in particular dengue. And I don't know that I can answer your question. Maybe someone else on our panel, do you want to speculate? Or rather, speculate on how do we improve the situation? How can we get improved global donor and public support for things like arboviruses? Do we need to strengthen our voice, be talking more about arboviruses, sending out more, you know, articles, directed scientific ones to, you know, the professional doctors and so on, but also, you know, more popular level articles to make the general public more aware, targeting the donor community better with targeted communication material. How do we go about improving the situation where, you know, there's a lot of apathy about arboviruses on this planet? It's improving, but it's still sadly not where we would like to be. Amanda, from your previous shoes with WHO, do you have any comments?
Oh, what can I say? All I would add is that it's such an overwhelming global challenge because there's no really easy preventative and control strategies, unlike other diseases. I think globally, institutions and donors love to get behind an exciting vaccine or other technology. And for dengue, I mean, there's some new technologies that are being explored, which is hopeful. But, you know, there isn't really like an easy let's vaccinate everybody, or, you know, an easy vector control when vector control's hard. It's not like, and also because a lot of the arboviruses, they're very ubiquitous, and they do cause deaths and sometimes very serious around the world, but they're easily overshadowed, I think, by other things. You know, classically malaria is the one that gets more attention. I hope that this will change with the growing impact of arboviruses. I guess that's all I would add. Thanks, Leo.
No, that's good. Yeah. A very appropriate response. Thanks, Amanda. I see Dr. Michael McDonald is still hanging in there, bitter end. Thank you, Michael. all the way from America, participating in this webinar. So, Wulan, do you think we can activate Michael and get Michael to respond to this question? If you don't mind, Michael, just give us a few words, pearls of wisdom from your side.
Yes. Hi, Leo. Can you hear me?
Yes, very clearly. Please go ahead,
Yeah.
Michael.
Yeah, and thank you for not putting on the camera because it's 1:45 in the morning here. But to your question, for years I lobbied USAID, rest in peace. I lobbied USAID for dengue money, and I was told there were a couple of reasons why donors were not investing in dengue. And Amanda listed some of these, but dengue doesn't cause the deaths that diarrhea, malaria, or pneumonia causes. So that's one issue. The bigger thing is donors don't have a direct return on investment. For example, for a malaria program, if you invest in $1 million worth of mosquito nets or drugs or diagnostics, you can expect, a certain decrease, a predictable decrease in malaria. You put $1 million into a dengue program, and you still may have an outbreak. And so donors don't like it because there's not that, as Amanda said, that easy fix, that, those easy technologies that you can put in and expect a return on your investment. And I put it in the chat that I think one of the things that we need to do as a community is, keep the focus on health. It is a health issue, doubtless, but also start highlighting the economic impact of arboviruses. And I often come back to the chikungunya outbreak in the Caribbean a couple years ago. It decimated the tourism and the cruise industry. And if we would focus, not just on the health, but also the economic impact of these diseases, I think that can help us make some progress. But let me stop there and go back. Excellent presentations. Thank you to Malaria Consortium for organizing this very important webinar. Over.
Thank you for those contributions, Michael. Let's make it one last question because we're running out of time now. So unfortunately, we have to wrap up. This one is from my very good colleague, Prudence Hamade, all the way from the UK. And Prudence asked Dr. Najmul, what factors contribute to the relatively high case fatality rate? Do you want to speculate on that, Najmul?
So especially for Bangladesh perspective, we know these are the case number that we are detecting or reporting through government's passive surveillance are those people who are coming to the hospital. So a large number of cases are actually undetected. So that, and especially the mild and asymptomatic cases are not contributing in the denominator. So that's why I think we are detecting more severe cases rather than the total cases in Bangladesh. That's why I think we have a higher case fatality rate in Bangladesh.
Thank you, Najmul. I want to apologize. Fikri, I feel very guilty and bad, my friend.
No, it's all right.
But
It's all right.
I just read the questions as they came in from the audience. So, and I kept saying,
It's
please,
okay.
what's one for Fikri? Come on.
I've been responding to them
Okay,
through
that's wonderful.
chat. So
Yeah, I
feel free
appreciate that.
to see that. Of course.
No, I appreciate that. And thank you for not getting upset about that. Thank you, Fikri. So I want to ask Wulan. Wulan, would you mind putting on the screen the poll questions? It's just 4 short questions for those of you who are still able to. Please, could you just respond to this little questionnaire? It's going to take you 1 or 2 minutes maximum, but it helps us. So to everyone, to our panelists, what a wonderful series of presentations. It was genuinely a genuine pleasure to listen to your different experiences, your different insights, and presented in such a professional way. Thank you sincerely to our audience members for being such wonderful participants hanging in there right to the end. Thank you for participating in this. To our backroom technical team, Wulan, Popo, several others at our Malaria Consortium headquarters, many thanks indeed for making this webinar possible. We appreciate it. And we look forward to our next presentation, our next webinar, which will come a little bit later this year. Thank you to everyone. Have a wonderful day. Please complete the poll, and we appreciate your time. Thank you so much, everyone. This background that you see for my picture is from Fikri's country. It's taken from near Salatiga.